I'm going to move on and talk then about how what's come out of these stakeholder meetings that Jill has told you about. So as Jill has said, we've had 2 stakeholder meetings and then lots of sort of communication out with those, which have really discussed what makes up physical rehabilitation, physiotherapy for stroke. And we spent time looking at the treatment components from the last version of the review, discussing what might be missing and how we might move forward from that. So it's been a very iterative process in moving forward with lots of back and forward conversations. But in terms of what came out really from the first meeting, it was very clear that there were 3 main points in terms of how we had dealt with physiotherapy in the last version of the review. So the people at the meeting, the stakeholders, felt that there were additional treatment components that were not included in those 27. So it wasn't particularly surprising there that they had some other things that they felt needed to be added to that list. But much more importantly, and the thing that they raised more loudly than anything, was that physiotherapy is more than just the individual treatment components. There's lots of things that surround that. There's these adjuncts to physical rehabilitation, and that came through loud and clear. And then also there was a real importance put onto the mode of delivery, how physiotherapy was being delivered. So I'm just going to briefly talk through each of these 3 main things that came out from the stakeholder meetings and sort of how we've moved forward with those discussions. So in terms of the treatment components, you've seen this slide already. This was what we had in the 2013 review. Various other components were added to the original lists that we had. So that was quite straightforward. We had some discussion. There was some challenges in working out whether things were modalities or assistive devices, and actually felt that the most pragmatic and sensible way forward was just to bring them together into one grouping. So that was reasonably straightforward. In terms of the much bigger discussion, and I say bigger, it was bigger in both of length of time and probably also in terms of the passion that people had for it. There were lots of other adjuncts, things that happened around those treatment components that people felt were really, really important and ought to be considered in some way within the review. So lots of things were brought up, and then we've grouped these together. Initially, we just had 3 groupings, and then through that iterative process, we've come up with a fourth grouping. So those adjuncts have been grouped together as the support that somebody gets to enable them to practice away from a physiotherapist. So that opportunities to practice activities. So that might be components such as having a family member trained to support some practice, or it might be a change in the patient's environment, maybe at their bedside or maybe at home, in order to allow them to practice a task independently. And then in the darker blue, there's that adjunct of what we've called cognitive information processing. This is all to do with the motivation and the emotional side of recovery. People felt it was so important that people were motivated and engaged in their physical rehabilitation. So sort of components and categories that were identified were things to do with goal setting and behavioral change techniques, and lots of loud voices saying that, you know, this is a key part of physiotherapy. It was also identified that interventions that are addressing other non-physical stroke-related problems may indirectly be having an effect, and we shouldn't be ignoring those. So that might be speech and language therapy, but one of the main things that people really highlighted was the psychological support, with people making that link between getting the psychological support to adjust to life after stroke, and how that then impacts on the motivation and the engagement for physical rehabilitation. So identifying that there is a link there. And then the final box in purple was to do with assessment and monitoring. So this is about how people gather and share and use information to inform treatment decisions. So then the third of those main points from the discussions was about this mode of delivery, how physio is delivered. And we've grouped these together into three things. It was really felt important that we should be looking at, is the physio given as a one-to-one session with a therapist, or is it a group or a mixture of those? Is it a face-to-face session, or is it in fact remote? And of course, there's been more and more remote rehabilitation happened over the last couple of years. Or is it a mixture of those approaches? And then is it an individualized physio session, so adapted according to the individual needs of that patient? Or is it a standardized approach, so maybe a standard set of exercises which are being delivered to all patients, or a mixture between those? So we were left at the end of these meetings thinking, okay, these are all really important points, and we've said we'll listen to the stakeholders and we'll change the way we're doing this. So we need to now have a review that is able to incorporate this complexity of not only the treatment components, but also these adjuncts and the way it's delivered. But also we didn't want to lose sight of the fact that this review has always been set up to look at the effectiveness of functional task training to improve function and walking and mobility. So that had to remain central to it. So we explored a number of different models that have been proposed to describe physiotherapy. And this one here that's on the slide proved to be quite helpful in our thinking. So this idea of thinking about the ingredients, so these are really our sort of individual treatment components at the beginning. So that's what the therapist is doing or selecting, how those things work, the mechanisms of action, and then what they're targeting. So thinking in this way made us think, well, this review is all about the target of function, walking, mobility. And then we've said that central to this is this idea of functional task training. So this is working by learning by doing, practicing walking, practicing standing. But then we had things that we came up with and in terms of mechanisms of actions, how we were doing treatment components which might change musculoskeletal systems, so strengthening, muscle lengthening, and cardiopulmonary interventions trying to improve physical fitness. And then those interventions that were based on neurophysiological theories. So they all seem to fit in there in terms of the mechanisms of action. And then we had all these huge lists of ingredients, all the big lists of modalities and assistive devices, like our electrical stimulation, walking aids, orthotics. And then the idea of whether the patient was being provided with opportunities to practice activities away from the therapist. And then the concept of assessment and monitoring and how that was informing the decisions about what treatments would be done. The important point of the motivating factors, the cognitive information process is obviously going to change those mechanisms of action. And then we also had those interventions that are addressing other stroke-related problems. So this was our attempt at bringing it all together into a model. So we had it all on one page. We then sort of simplified that a bit, so it was presented like this. Under each of these coloured boxes is a whole list of individual treatment components that our group have defined. So if I show it to you like this shows you the sort of complexity with what they've been working with. So they've developed all these individual treatment components. Each of those treatment components has then got a written definition that the stakeholders have come up with. So we've got a document then that's several pages long, which then defines each of these. But I'm just going to go back to the simple one because it's easier to look at the moment. So how are we planning to use this within this next version of the Cochrane Review? So what we're planning to do is make sure that for every study that is included in the review, we describe the interventions in this way, and we have a sort of categorization so we can say whether they've been using neurophysiological interventions, what modalities or assistive devices they've been used. And then we will use the model to also structure how we bring the evidence together. So our thoughts and what we've discussed with the stakeholder group is that our sort of main analysis, our main way of bringing the information together will be what's in that circle. We're interested in the mechanisms of actions and whether physiotherapists are using techniques to change musculoskeletal systems or cardiopulmonary systems alongside their functional task training. So that will make up our main analysis. But then we will look at all these other things within what's called subgroup analysis. So we will do analyses to see whether there's any evidence to show that if you're having opportunities to practice away from your therapy sessions, whether that seems to be having an impact on the outcome. And then also we'll have a set of subgroup analyses that are structured around those 3 different types of mode of delivery. So that is where our stakeholder group has got to in terms of bringing the model together. And we're just at this point this week of starting to pilot how this is going to work in terms of us using it with the review. And really now what we want to do is have a checkpoint with you and see whether what you think of that. Does it make sense to you? Would you change it in any ways? Anything that doesn't make sense? So we have a couple of polls that Oliver is going to run just while you gather your thoughts. And then Julie is going to read out some of the questions that you've all been putting into the chat. So the first question there is whether you agree this makes sense. So looking at that, it's looking like 80% odd are agreeing. Oh, at the last minute, then with one person disagreeing in terms of it making sense. So I think that's something we're interested in exploring. In terms of our 75% threshold that Jill mentioned earlier, I sort of feel reassured that we have got over 75% of the audience here who seem to think it does make sense, but we probably need a bigger discussion around that. And then we had a second poll question about whether you felt it was comprehensive. So do you think it's covering everything, or are we missing things from it? And please, if you do think it's missing things, then please put them into the chat. Even if we don't go through it all today, we will be going through it afterwards and making sure that we incorporate things that you think have been missed. Okay, that looks like it's about people done. So we've got about 75% agreeing. 5% who disagree with the terms of it being comprehensive. So again, if we've got things that are missing, please highlight those to us in the chat.